Excuse me. Hi, everyone. Dialysis nurse Lindsay here, and I just kind of wanted to jump on live and talk about dialysis disequilibrium syndrome. It is a mouthful, so you will, oh God, it is a mouthful, so you will hear the term DDS in the dialysis clinic or in the hospital if they're thinking about DDS on one of the patients. So first, I will kind of give a brief definition of what DDS is. It is an acute neurological dysfunction from cerebral edema that is caused by hemodialysis. So this is something that is caused by dialysis. And one of the hardest things with DDS is that it mimics intradialytic symptoms. So here are some of the symptoms that they list for DDS. Symptoms are malaise, headache, hypertension, nausea, vomiting, muscle cramps, tremors, blurred vision, and this can all lead to seizures, convulsions, altered consciousness, coma, and even death. So when I first started dialysis nursing, I had a really hard time understanding why, or the rationale as to why we stagger our dialysis treatments, why when we first do dialysis, our goal is inadequate dialysis. And one of the reasons for this is to help prevent dialysis disequilibrium syndrome, to help prevent DDS. And the key to knowing the difference between if your patients are having intradialytic symptoms or if they are experiencing DDS, it's important to be aware of who is at highest risk for DDS. And DDS, the people that are at highest risk for DDS are people with severe azotemia, so people with an elevated BUN. When I am caring for patients in the hospital, if their BUN is over 100, I am thinking about DDS. I am looking for those signs and symptoms of DDS, and I'm ready to call the physician or the provider. And that kind of goes along with their other risk factor for DDS, and that is it being their first couple dialysis treatments. A couple other people who might be at higher risk for DDS are people that frequently miss dialysis treatments. So they might go, a week, 2 weeks without dialysis, show up to the clinic, and they'll have an elevated BUN. They'll still have their 4-hour treatment and will drop their BUN too fast, causing cerebral edema and DDS. So those are people you need to be watchful for. And also people whose maybe their fistula hasn't been working well for a while. You were able to kind of get through, but you weren't cleaning their blood very well. And then maybe they had a fistulogram, they had the first fistula worked on, and now you're taking care of them, and we're again dropping their BUN too fast. We're lowering their urea, and that there's a couple. The pathophys of DDS is kind of not well understood. There are 3 main theories, and I don't know which one's right or wrong, but one is called the reverse urea effect. The other one is changes of intracellular organic osmolytes, and the other one is changes in regards to the pH metabolic acidosis that our dialysis patients have. And honestly, it doesn't really matter which one is right because the treatment is all the same. And the treatment is to give inadequate dialysis their first couple of treatments. So if you're in the hospital, if their first dialysis is on Monday, you might have a 2-hour treatment Monday, 2.5 Tuesday, 3 hours on Wednesday, and you're going to have a lower BFR, a lower DFR, and you're going to have low fluid removal. And you are working very closely with the nephrologist to make sure that you are providing safe dialysis. There are people that come to the clinic that come straight from the nephrology clinic to the dialysis clinic, and they've never had dialysis before. And this is where you need to be really mindful of what their labs are. Have they had dialysis before? If they haven't, is their current prescription appropriate? Did an order get missed? First dialysis treatments you need to go slow. You need to have a low BFR, low DFR, and usually most patients that are first in the clinic, if the physician didn't write for a UFR goal, I'll call the provider and I'll give them my assessment and ask them what kind of UFR we should be providing for them. Because even when I set them for no fluid removal, I will still see that crit line drop. Their body is not used to dialysis and they need time to get used to it safely. All right. I don't know how to work Mrs. Potato into this scenario, but I'll kind of talk about some of my experiences as a dialysis nurse, especially in the hospital where I have experienced DDS or symptoms of DDS. These people have had an elevated BUN, 100 or more. I remember the first day I did a 2.5-hour treatment, and just at the 2-hour mark, that his blood pressure went up. He got nauseous, he started vomiting, and he was very restless. And my first intuition was to treat the symptoms. My first intuition was to put them in minimum UFR and notify the nurse to get some kind of anti-nausea medicine, or maybe some Tylenol or something to help with the symptoms. But the thing that you need to be very watchful for, the thing that you also need to be thinking about is what is causing these symptoms. What are the reasons for this? If it is DDS, you need to do more than just treat the symptoms. You need to call your provider. You need to stop treatment. At no point, if at any point I am providing dialysis and my patient becomes unstable, I will give them their blood back and pause the treatment, make sure they're stable, and I'll call my nephrologist and tell them what is going on. If they want me to restart the treatment, I'll restart the treatment. But if they're not tolerating dialysis and they're unstable for it, they need to know so they can develop a plan of care for them in the future and know what to order for their dialysis treatment the next day. What else do I have in here? And the other key thing with this is you just really need to educate your patients about DDS, or just things that can happen during dialysis that they need to tell us about. You will run into people that just, don't want to be a nuisance, and you need to tell them these are things that can happen. Dialysis takes a little bit of time to get used to. We're going to start with a 2.5-hour treatment, and even write it down. This is what the needles are going to be like. If you develop any of these symptoms, if you get a headache, nausea, vomiting, you get restless, blurred vision, I need you to tell me, and I will be checking on you frequently. These are signs that you're not tolerating dialysis well, and I need to do an intervention, and I know how to fix this. I will fix this for you. Those are like my key things about DDS. There's this really cool, I am a member of ANA, so I have some of these ANA articles, and I was thinking of maybe doing a dialysis DDS in kind of case study. There's a journal article about it. What else? Do I have another piece of paper somewhere? I guess I lost it. Oh, here it is. DDS is a complication that can be fatal. It is under-detected and underreported. So this means that you might have experienced DDS in the dialysis clinic or at the hospital, and you didn't even realize it. And whether or not you know it or not, you just need to be assessing your patients and notifying the provider, and really thinking the one takeaway I want you to take away from this is it's not only about treating the symptoms. You need to look at the root cause. You need to know why this is happening. That's it. I got my potato people. This is a real life potato head. They're so cute. And my little dialysis thing. If you guys saw my fire video, I had too much fun with that. Let me see. Anybody have any questions for me? Anybody want to? Anything I missed? Anything else about DDS that you guys think is important to talk about? Any questions? I just love it all. It's a live stream. We're doing a live stream. We're Oh, how to cope being a new nurse in dialysis. That's a great question, and I find that a lot of our new nurses, our new graduates, do very well at the dialysis clinic. You guys are very coachable. You are so eager to learn, and you're so excited. Oh, you still don't know enough? I wonder what you struggle with. I would say that it definitely takes a year before you get comfortable as a nurse. So I think that you will kind of hit that peak, and you'll start to grow. Really, the machines are good. I would really narrow in on your assessments. Are like labs an issue? Well, I feel I don't know enough. You don't know enough. DDS, so I think I learned a lot during care conferences when we had care conferences and spending time with the physician. Whenever they would teach the patient, I would learn a lot. I also, I joined Anna. Oh, good. I know you're doing great, but I'm happy that you want to learn more. If you are interested, I felt when I was at about the year mark was when I started studying for my CDN, and I learned so much studying for that test that my confidence went up, and I felt like I could really do a better job educating the patients on different things. So even uh, if you are interested in joining Anna or doing some kind of like review course or even the dialysis tech handbook, looking at those things, practice questions. Yeah. Honestly, one of the things that sometimes it's just fake it till you make it. Answer their questions. And sometimes I'll ask, I had a lot of questions about iron at first. I would talk to physicians about iron and just kind of, they know there's a lot to learn, and just kind of doing the journey with them and talking to them about fistula and catheter infection and just being confident in yourself. And sometimes as you're teaching, you're learning as you're teaching. And it just takes practice. And before it, I can't say that I always felt like I knew what I was talking about, but the longer that I did it and talked to patients, asked them questions, and if I didn't know it, sometimes I'd do a quick Google search. I'd be like, okay, and following through with patients, developing trust are amazing. Assessing my patient could use improvement and have encouraged with patient education. As far as like your assessment stuff, there's a lot of assessments. Struggling with education paints about labs also. I have a good iron EPO playlist that you can check out. The renal osteodystrophy, the phosphorus calcium stuff is super complicated. I've been spending a lot of time trying to research those things. Phosphorus and calcium, it's all about bone health. I'll just kind of go back to assessments. Assessments just really focus on infection prevention and prevention of fluid overload. Focus on those two things and the rest will happen. If you are assessing a fistula and you're not really sure if it's failing or if you're having issues with it, kind of take a look at the pressures, talk to the patient. Have we been cannulating? Any problems cannulating? Any problems bleeding? And sometimes just kind of going along the map of asking questions will help you get the answer. And then the more you talk to the physician, the more you'll know what kind of questions they have, and you'll be ready to talk to them. Patients about labs. So the biggest thing, our clinic focuses on whether or not we're cleaning their blood enough, so their URR, and a big focus is on anemia. So talking to them about that, your kidneys are amazing. They do so many things, and they also help with red blood cell production. Usually our kidneys produce a hormone called EPO, but now that you're on dialysis, they don't produce that hormone anymore. So we are going to give you that hormone to help produce EPO so you maintain a healthy hemoglobin. People with low hemoglobin have fatigue, they're pale, shortness of breath. So giving you this EPO will help with your energy. The other thing with iron is people on dialysis just need more iron. They lose iron, whether it's with blood draws, blood getting lost in the dialyzer, bleeding after dialysis, and there's a higher turnover of the red blood cells. Their blood cells don't live as long. So that's another reason why we need to give iron. So EPO and iron. And then I just like to throw in that their multivitamins important too, because it's got some folate and vitamin B12. As far as Zemplar or vitamin Zemplar, what's the other name for Zemplar? Calcitrol, Zemplar, the binders, that's more long-term things. I need to Hectorol. I'm not sure what that is. Let me look that up. Hectorol. I think, is that something that they put in the diet, in the buy card? Hectorol. Oh, it's a type of vitamin D analog. So the biggest thing, wish had it been here, there is When people have a higher level of phosphorus in their blood, they have high levels of phosphorus in their blood. Usually plan A is that my kidneys will take care of it and excrete that phosphorus in the kidneys. Now that your kidneys aren't working, your phosphorus is building up in your blood. The dialysis machine will clean some of it out, but for many it's not enough. So the body goes to plan B. Okay, I need to get rid of this phosphorus. How am I going to do it? And it binds with calcium. So your phosphorus in your blood is going to find calcium and bind to it and give you that calcium phosphorus product. The number one source of calcium for this phosphorus is your bones. So it starts stealing your calcium from your bones, and they're long term, they are going to have, bone disease, osteoporosis. And I have seen people cramp so bad that they crack a rib. Okay, so it is long term. This is really important. And the other thing is with that calcium phosphorus product, it builds up in the body and it attaches to muscles. And like your heart is a muscle, and the vessels, and it'll cause like calciphylaxis if you've seen people with those necrotic wounds that are a result from uncontrolled phosphorus. And to be honest, the people that I've seen that have been on dialysis for so you give it with iron and EPO. So iron and EPO are going to be specific to the anemia, and then the Hectorol is going to be specific to making sure that their body doesn't steal calcium from the bones. So one of the ways that your body knows to release calcium from the bones is PTH. So I have a high phosphorus, and the body, your parathyroid gland notices this high phosphorus, and it says, oh my gosh, I need to release some parathyroid hormone. So my body starts releasing calcium from the bones. So high phosphorus means high PTH, which means stealing calcium from the bones, which then results in all of those other things that I just talked about. So being able to Hectorol, so giving the patient vitamin D, it will help the patient absorb calcium through the GI tract instead of taking from the bones. So one of the side effects of Hectorol is having too high of a calcium, and that would be a reason to hold it. So instead of stealing, Hectorol's goal is, instead of stealing the calcium from the bones, high PTH means that your body is stealing calcium from the bones. Okay. Oh, good. It is complicated. I do kind of have another video that talks about it, but it is complicated, and it has taken me a while to I really started understanding the renal osteodystrophy, the calcium, phosphorus, PTH kind of triangle when I started studying for the CDN, and you guys can do it. It is so rewarding. I enjoyed taking the test. I think I have a video on my Instagram of it's the best thing. Labs will come. Those are kind of like just the last puzzle pieces. And then it's just all of a sudden one day it all makes sense, and it's awesome. And I still have to ask questions. I still don't know everything. Of course I don't. I still rely on other people to help me with cannulating, machine troubleshooting. What do I do with this assessment? And my providers have been a great resource for me to learn, and the experienced dialysis nurses, talking to my manager, talking to my other colleagues. And there are dialysis techs that know these patients really well. I really rely on my dialysis techs to help me, because they see them more often than I do, and they know them better. And when they tell me that someone's not acting right, I listen to them. Oh my gosh, I'm so happy you're in dialysis. Just kind of jump in whenever there's opportunities to kind of get involved and do things. I would definitely do that, and that'll help you learn. And so I'm glad I came across your channel. Oh, good. That is why I'm here. That is why I started this channel. Dialysis is so niche. I was in nursing for 8 years, and I took this job not knowing a lick about dialysis. I had no idea how much water was involved. The fistula, all I knew was I couldn't touch the catheter. I had no clue. And I've been at nursing for 8 years, and I didn't know about, anemia and phosphorus and fluid. I didn't know anything. So it's so niche. It's so special. I really feel like now that you've, hit that year mark, you're going to be a dialysis lifer. And I'm just so excited for you. I don't know. I wonder what I should talk about on my next video. I've kind of hit a, what's it called? Like a roadblock. I've been having fun on TikTok and doing some fun TikTok videos, but YouTube is my home. Oh, yeah, that I feel like dialysis techs, we have a few dialysis techs that are in nursing school too, and there's so much hands-on experience for you. I'm sure you went into nursing school, not afraid to cannulate, not afraid to touch a catheter, just really, really comfortable with patients too, which I would recommend dialysis tech to any nursing student for sure. So I'm so happy for you. Such a special world. If you ever get the chance, like my dialysis clinic does acute and chronic, so we jump in between the acute and chronic, which it's nice. I learned a lot in the acute. I got more experience in the ICUs and became more comfortable in the ICUs. Oh, that is a great idea, because oh my gosh, 4 a.m. wake up call comes early. That is, I love that. I love that. I'll start brainstorming a little bit. Keeping healthy. Yeah, I have a treadmill and I have not been on it in weeks. So it is an important thing. Yeah. Thank you so much, Naturally C. I appreciate you so much. If you have not joined our Facebook group, I'll send a link, but it's dialysis nurses supporting nurses. And there are a lot of great nurses and dialysis techs in that group with a lot of different experiences throughout the country. And they've helped me a lot and have helped give me perspective on other things. And I'll see you guys in the Facebook world. I appreciate you so much. All right. Bye, you guys.